we can perhaps, begin with today there has been this Supreme Court ruling, as it were. The odd statement, which I think from a hospital perspective is important, that regulation, that there should be a standard pricing that government would give for procedures and treatments. If there's some thought which we can begin with, Dr. Ajay, if we can start from there, because that has been the news, and we from the media, we like to hang our hat on the news item of the day. So if we can begin from there.
See, my view is very clear. There is a private enterprise, there is public enterprise. There is a choice. When a private enterprise does healthcare, we have insurance where we negotiate with insurance. Pricing is there. There are schemes which already have certain negotiated prices. Then there is cash paying patients who don't want to take insurance, who have to pay. Now, when you don't take any help from the government, when you have a free, can you go and regulate? What are the things you can regulate in life? So when a regulated society comes, it will certainly drop the quality of care, the sustainability, viability of the whole thing. It can destroy the system significantly. In India, we have, I have practiced in US for 28 years. And having come to India, I can say, particularly in a field, oncology, which is a difficult field, we have one of the best qualities in the world when you take the major cities. India is like two countries. We have 300 to 400 million moving up the ladder, affluent, demanding the best of healthcare. Then we have lower socioeconomic group, which is 900, trying to come up the ladder. The challenge should be how to bridge the gap. Because technology has advanced so much. Today, a cancer patient or a patient with a lump in the breast or a abdominal pain comes. In 3-4 days, I can make a diagnosis and start the treatment. Phenomenal. If you look at UK, US or any country, they have to wait not just weeks, months. And our own country doesn't recognize the damn thing. We are so stuck on cost. We do a PET scan for $20,000. With no government help, no grants, it costs $2,500 in US. The cost of heart surgery may be $2,000 to $3,000 in India. It could be $35,000 to $40,000 in US. And some people want to go to the right doctor here also and pay the right amount. There are doctors in India who earn equal to US doctors because they are talented. So it is 77% of healthcare is provided by private healthcare. Interfering in this, intention may be good, for the wrong reasons can be catastrophic. I think also that most of the money we do, we are a listed company, HCGs, is flowed back into the system. We don't give dividends. Hardly any hospitals are giving dividends. But it is helping the system to grow. Private equity, others have sustained it. When they start interfering, you will destroy private equity, private funding, everything you will destroy, and we might as well nationalize healthcare. We all will go and find some other work. We'll start food chains or something else, maybe shoe shops. So please don't interfere with what is going on, but there is a way to correct it. Bring universal healthcare. Like I was showing Kumar today, I have a Medicare card. I was in US for 28. What that means, I can go to any hospital in US because I paid for it, and today it's free care. So what you do, Brazil has done, create a universal healthcare with no limits. Create an endowment, create a fund like Canadian government, a social security fund that can actually invest in stock market, make money. Today Canadian fund is 800 billion, takes care of all security. Like that you create a fund. It could be cess based on your telephone. You all have smartphones. You say if you are working as a doctor, if you are a auto rickshaw driver, you have to pay so much. Based on it, collect money, let that money grow, make it an endowment. So many times we have returned to Niti Aayog on this. Do it. But they are not. And they bring the drug costs down to the flat bottom. For example, a drug called cisplatinum Taxol has been brought down from 15,000 to 1,000. No pharma company wants to manufacture it anymore. What are the cancer patients going to get when it stops? They're beaten down to the hilt. Why should a person in affluent also pay low price? Why not cross subsidy? You know, these are some of the, and you talk about low cost schemes. Are we measuring outcome of these schemes? As a patient who is under scheme, is he getting the same outcome as people who are paying the right price? No. In our analysis, 44% more mortality and morbidity because you are cutting, you are paying for esophagectomy. You know, to do esophagectomy, if you pay 25,000 rupees, who will do right esophagectomy? You know, we may be doing, but a lot of them will compromise. And who will give right? I had a patient recently in my clinic, 28-year-old in the tumor board. They said the patient died with advanced disease breast. I said, why was not Herceptin given? Sir, the scheme doesn't pay for it. She would have lived for 10 years if the scheme had given. Why are you all not questioning that? We are simply accepting whatever government says. I think private enterprise also to be blamed for keeping quiet. These are all radical changes are needed in the healthcare, Kumar. Today, we are at crossroad. We have now brought the platform, cardiology, oncology, orthopedics, to the global standards are better. Our outcome is now better than MD Anderson breast cancer. We have brought that to the level. But now, how to sustain it and bridge the gap should be the discussion. Not saying monitor the cost, bring down the cost, then squeeze the system and kill the system. That is what we'll have. Anywhere, you have brought price control, the system is definite to be killed. I can assure you what is happening in pharma. They are killing the pharma system now. And nobody wants to manufacture cisplatinum. And so even US is suffering. That's not our issue. Because nobody is willing to export cisplatinum to US. Because we can't even manufacture. So these are some of the systems. It has to be in-depth. There is a disparity. People need. There is a public system. Let people, like people come to us and they can't afford. They say there is a hospital down the road, which is a government hospital. Go there. Why are people not going there? Why is the quality care not improved there? If the quality is good, they can go there. Who is preventing them from going? Am I? No. So this has to be discussed in depth. Supreme Court, anybody can pass any order. But is that the right thing to do has to be debated. And I think certainly it will cause so many problems. It's unbelievable. So, but we have to display the price. We have to be transparent. I totally agree. You have to tell the patient, if you undergo robotic surgery, it's going to cost you 4 lakhs. If you undergo this, be very open, surgery and do it. Transparency is very important. And the patient says, I don't mind paying, okay. If you cannot, what are the alternatives? But don't deceive the patient by giving a different number and charging them more. I think, and also all these issues come, is the patient kept in ICU longer than needed to make money? All of that. So then it comes margin. I will be very vocal. Any hospital chain which makes a very high margin, there is a problem. Margin should be reasonable, 20s, low 20s, so you can plow the money back. If somebody says, I'm making 30%, you're squeezing the patient overall. So that also has to be addressed. So these are some of the finer things we have to go into the depth before we say how to bridge the gap. But universal healthcare is the answer. Where rich or poor, they get the same care and no bars, no limits. This is the way to move forward, and there is a methodology to that.
That's a very nice and a very strong statement, but very important, very pointed. I think like typically you have been always very clear about what you think and what you say. To the regulator NABH, before I come to you, sir, Atulji, I would want to get on this perspective from Pankaj and also from Dr. Verma. Pankaj, your point about, are you equally strongly feeling about what was announced on the Supreme Court thing? Are your views similarly strong?
You see, my point of view is that unfortunately, when we look at the conversation around healthcare or Indian healthcare, we like to go for 4-5 very high-level headlines without understanding that healthcare has extremely complex nuances. And unfortunately, we are kind of trying to, close the barn door after the horse has bolted kind of reaction. So Does India have a challenge with the affordability of healthcare for its public? Of course we do. Does India have a challenge with availability and access for healthcare for its public? Of course we do. Frankly speaking, if we look at all of us sitting in this fancy five-star hotel, healthcare is expensive for us, forget about for the population of India. This is not breaking news. This is something I feel on panels like this we have been discussing for 20 years, nothing seems to change. So I don't think that one particular event or one particular interaction is going to randomly change that, and I think like with many things, our reactions cannot be knee-jerk. In healthcare, you have to look at multitude of things to this. So I do agree with Dr. Ajaikumar that blanket price capping may not be the solution. I also don't think that in 10 minutes on a panel discussion you will have the solution. I think it's quite a complex discussion. The problem that I see is that people are not willing to invest the time in that complex problem solving. People are looking for the easy solution, so you can put it on the sticker and say that we did this. And for that, I think we are all to blame. I think private enterprises to blame, I think government enterprises to blame, I think the media is to blame, and frankly speaking, the public is also to blame. You know, if you just look at it from a point of view of the other side of healthcare delivery, which is the payment of healthcare delivery. We've talked a lot about insurance. We talk a lot about government schemes which fund healthcare. Now, it is not like 25-year-old people in India are thronging to buy health insurance. When are you buying health insurance? When you already know that you are sick. When you already know that you will be requiring this claim. When you look at the people who are claiming the government insurance, it is not like this is only the people who are economically poor off. People will come in a Mercedes and produce an Ayushman card. This happens in all private hospitals in the country. How is it that the length of stay of patients who the government is paying for happens to be longer than the length of stay of patients that are paying for themselves? Did the disease suddenly attack the government paying patients in a more aggressive manner? I don't think so. They are also manipulating the system, staying longer because somebody else is paying. So I think that it's very easy to cast the blame on one side or the other. This problem is extremely complex and we need to address it in a very, very granular way. The other thing that we do when we talk in these conferences, and the speaker before this discusses, we talk a lot about healthcare as if the problems of healthcare are with the doctors and the hospitals. Actually, they are doing disease treatment. They are not really delivering healthcare. We don't actually spend a lot of time talking about health. We don't spend a lot of time talking about prevention. As a society, healthcare starts at the primary level. Healthcare starts with lifestyle choices. Healthcare starts with the pollution. Healthcare starts with the food we eat. Healthcare starts with the lifestyle we lead. So I think if we as a country are looking to address all of these, it requires a kind of multivariate analysis. It requires a kind of multi-pronged attack where we all need to come together. And that, by the way, includes things like the equipment to deliver healthcare. If everything that you use to deliver healthcare has to come from outside of the country and you have to pay millions of dollars for it and duties on top of that, how do we expect to become self-sufficient as a country in the delivery of healthcare? So I do agree with Dr. Ajaikumar, this is not a one-strike kind of a solution and then everybody is happy. This is an extremely complex issue. And we will get to it stage by stage, but it requires all the parties, and really I mean all the parties, to come on the table and actually put in the hard work. Unfortunately, we are looking for the easy solution. I fear that in healthcare there isn't one.
Yeah, I think, no, thanks for actually bringing the thought to the way we should realistically look at it. Yes, it's given that we have a regulator here and we have the dean from AIIMS, one important element in this whole process, and some of the things which Dr. Ajaikumar also mentioned about quality and all of that, the issue that often comes up is that maybe there are select few hospitals, select few chains, select few known big entities who are actually delivering quality. We are global in some sense. We are the global north in some sense of the way we deliver some of the healthcare outcomes. But quality is still a challenge. So, how do we therefore look at it as someone from AIIMS and who's looked at this space, and you have been a big mentor for many, and now we are having more hospitals coming up. can you throw some light in terms of how you look at, while with the volumes in the hospitals which we have, how do we look at now the next challenge of quality, of the talent, of getting the people in place, and also the clinical skills? I mean, often we hear, we had a diagnostic session where the doctor actually these days just looks at the report. That old system of actually feeling the patient is actually gone, the clinical skill. If you can throw some light on that, from there I would want to come to our regulator, Atul ji, to get a perspective on how he looks at the landscape now. So if you can begin with that.
Thank you. Thank you, Mr. Sharma, for inviting me to this Financial Express Health Summit. I think the director was the original invitee, but I'm here by default because he is busy with somewhere else. Looking at, say, the healthcare delivery in our country.
Can you get the mic closer to you?
Yeah, the healthcare delivery in country, it has become a challenge. With the enormous number that we need to cater to, it's, 140 crores. And the government sector has the limitations. So we need to have and also need to support the private sector in that situation, because they are contributing to very important segment of providing the healthcare to the people. Now, looking at, say, the quality and the numbers that we are looking at, I have been associated with AIIMS for over 40 years now. And I have seen primarily the public sector, the government sector from the beginning. And when we look at the quality and matching the numbers, our hospital, the daily footfall is about 50,000 people coming, and there are about 15,000 people who are attended every day in the OPD basis and in the clinics.
Every day?
Every day. So now we have to look at as to how we are doing this and maintaining the quality. We have a system that people have to have an appointment, and they are indeed given adequate time. But in the process, then the waiting time has gone up. Somebody seeking an appointment through the regular channels probably will have to wait for 2 or maybe 3 months. But there are channels where the emergency care is there, which is provided. And we have tried very hard, and we are still able to maintain quality in terms of, say, the healthcare delivery, despite having had the challenge of increasing number every day. And we have to put a cap that, yes, we can take only these many number of patients or these many number of surgeries every day. So what we are doing, the government has made an attempt to set up AIIMS-like institutions elsewhere in the country with the idea that these institutions can provide the care to people who are coming from far-away places in the name of AIIMS. So
and how many are there today now, the last count?
I think we have about 22, out of which about the functional ones are close to about 15, 16, they are working. And several of them have the postgraduate training programs also. And the others are in the process of, they are just starting. So the idea was that, yes, these institutions or these healthcare centers, they should be able to cater to the need of people who are traveling, say, far-out places to the AIIMS because of the credibility that we have, the confidence that we have in the people that, yes, we can provide best of the care available in the country, and we remain the #1 hospital still in terms of the healthcare provision. And also, what has happened that despite these hospitals and these AIIMS-like institutions being there, we still have people coming from those places because of the confidence, the trust that the people have. When they come here, we tell them that you go back, why don't you go to AIIMS Patna, which is already there, where the person from Bihar will like to travel to Delhi rather than going to go to Patna for the treatment there. Because those institutions still will take some more time to come to the level that the quality of care which the AIIMS Delhi is providing. And also the putting up the faculty, the manpower, and the skilled, the health staff, that also has become a challenge in the sense that we don't have that level of the faculty, the staff who can be looking after those patients. So we have been able to maintain quality, and we have also been able to address to the numbers. And the hospital, the AIIMS, as such, has made the expansion within Delhi also. We have now about 8 centers, which are the super specialty centers. We have trauma centers, we have eye center, we have cancer hospitals in Jajjar, we have de-addiction centers, then we have rural center, then we have separate the cancer hospital within the institute also. So trying to expand the services within the campus and maintaining the quality is on one side that the effort is on, and also trying to support the other AIIMS-like institutions across the country to handhold and also train their faculty and the staff and provide whatever help that is possible also. But our emphasis has remained that yes, we would need to and will continue to provide the quality health care. And of course, since we are the public institutions, we do not charge any money for that matter. And that's one of the other reasons that the people, they get attracted. They try to come, join the system, whatever difficulties they may have, because they can get the best of the care at almost no cost.
No, I think that's important. Atulji, from NABH perspective, see, there are two things when we look at public hospitals and the private hospitals. See, some of the best doctors who are there in the private sector also, there are many times we see they have actually been government hospital products. Some of the best hospitals. So then they come from government hospital. But if you want patients to go to hospital, if you take top politicians also, where they get, when they fall ill, where do they get admitted? Yes, sometimes AIIMS is there, which is a good example and a lodestar from many perspectives in the private. But if you look generally, if you look across the country, usually it's always in the private hospital that they land up. So how do you as NABH, let's say, look at this challenge? How do we, what keeps you up at night when you look at this landscape?
Thank you, Mr. Kumar, and thank you for having me here. So just a quick background, I mean, not an assumption, a fact, that ultimately we are an emerging economy, one. Two, we spend about 1.7 to 1.9% of our GDP. And we aspire to do probably in the next few years to 2.5, 2.7, which are the quoted figures. Secondly, India.gov lists out about 1 lakh hospitals, not counting the clinics and other things. So that's a background. And there's a short story. This conference was to be held at Bhikaji Kama Palace, and I got an invite for that. And when I reached there, so I called up Sanjay, and Sanjay mentioned, no, it's happening here. So I came here, so no harm done. I live to tell the story. But similar unintended harm. So this is the classic example of an unintended harm. Please don't penalize anyone, we promote that. So classic unintended harm in healthcare industry is the top 10 causes of considerable mortality and morbidity worldwide, right? So with that background in mind, today NABH touches about 20,000 hospitals in 12 countries. Outside the country, we touch about 13 odd hospitals. In India, we touch and we continue to add about 250 hospitals every month. But the rest of the 80,000 hospitals, you can safely assume they are not following standard SOPs or quality practices. So that keeps me up at night. That is one. It's largely unregulated industry, largely. We were just discussing outside that healthcare in India is a 10 lakh crore industry in caps, right?
And in which the top line of the leading hospitals is about 50-60,000 crores.
Listed entities which you can count on your finger, including the diagnostics. Dr. Lal is here, Dr. Shah is here. So they do not total make up 1 lakh crore. So where is this 9 lakh crore? It's unbridled profiteering which is happening. Unbridled. I mean, probably court has, but I'll not delve into that. It's a very, very complex issue. I'm not qualified to debate on that. But the problem here is that majority of the hospitals, those 80,000, are still fighting their challenges of patient safety, quality, there's no check on them. I mean, healthcare unfortunately has been a state subject. We are a federal country, and healthcare and education, both key components are decided by the states. So there are some states which do phenomenally well, like state of Gujarat, Rajasthan, Kerala, Karnataka. They are fantastic states. Where every public funded institute in state of Gujarat today, even to the level of PHC, CHC, is today accredited, thoroughly, fully accredited. They have SOPs, they follow protocols, but that's not so in majority of the states. So that's one bane. So going forward, I think there's lots of optimism. Things are changing. The entire concept of in India is about 18 years old. The concept of healthcare quality, the structurality, the rationality, as Mr. Pankaj has very highly and articulately pointed out, that it's a very complex issue. We need to sit together, debate, do the costing. So under Dr. Lal sir, at FICCI, we have, thank you for making me a part, we have constituted a committee for costing. So probably we'll work out rational costing somehow. So not going into the entire things, we need to leverage technology, of course, as sir has mentioned, Dr. Ajaikumar has mentioned, we need to leverage technology. We need to communicate well, we need to make a patient-centered approach. So all those things are already there on the agenda, but somehow we all need to come together and, work together for that thing.
Very important. Dr. Ajaikumar, you mentioned this point also earlier whenever we had discussions about the disparity, some of the elements which Atulji also mentioned, the cost versus benefits versus outcome. Within India, there is, I'm not referring to the K-shaped recovery, but we're looking at, there is when it comes to healthcare outcomes and healthcare treatment, there is a Scandinavian scenario and there is a Somalian scenario as well. Maybe extreme ways to describe it. But so how do we therefore deal with this challenge?
Like I briefly touched on it, Kumar, we have to really think of this to bring uniformity of care. In India, when you look at 300 or 400 million as big as United States, getting high level of quality of care, but it is only 25 or 30% of the entire population. But the volume is equal to United States. But what happens to the other 900? Why is it has not bridged the gap? Like what Atul said, how much money we are spending. United States spends 18% GDP, we are spending 1.5%. So, you get what is for your buck, as they say. So we are so much immersed in this cost business, we are honestly forgetting the quality and outcome. For example, whatever the schemes pay, how many times the government is looking at what is the outcome of these patients? So if suppose in cancer or cardiac disease the patient dies, nobody questions. But they question what is the cost. I think we are missing the bus here by not emphasizing on the quality and outcome. So this brings us to the question, what should be the role of the government? See, Niti Aayog and all have made some recommendation. Very clearly, the government should become a monitoring agency. We need institutions like AIIMS for training doctors. There is no question. High excellence, centers of excellence. But beyond that, at all level, whether it is districts, hospital or a level, can we look at government with NABH and others to becoming a monitoring agency? Government cannot say, I will also do hospitals, I will not monitor myself, but I will monitor others. It cannot happen. It can
but for training, you also need hospitals, isn't it?
Yeah.
But for training, you also need hospitals.
Training, they can be done in the AIIMS and other institutions or even private. Now the DNB program is there, a lot of people are being trained. So there is a system which can be enhanced. But government should decide, am I willing to become a service industry also and do only monitoring? I think if government becomes monitoring, today technology is so advanced, government says, Mr. Somshekhar is my patient who is coming to HCG or going to Medanta or any hospital. I will pay you so much is what I think you have agreed, signed an agreement. Now I want to make sure they get the same outcome of somebody who is paying, cash paying patient or coming through other insurance. So then you bring parity in healthcare. But as long as that is not there, you are underpaying or you don't know what you're doing, you're swimming all the time and going from pillar to post, finding an answer, it won't work. It has to be uniformity of healthcare. That is the only way. Whether you're going to fix the cost or not is a different story. Somebody wants a private ward, somebody wants this, it will all change. But basic health should be equal to everyone. You cannot deny a 28-year-old trastuzumab because the policy doesn't pay and let her die. We cannot. This is not unacceptable. Immunotherapy, phenomenal. I had a boy with nasopharyngeal carcinoma. He was considered late stage. He lived for years, only son, because immunotherapy cost 28 lakhs. Government didn't pay, but we raised crowdfunding and all. But it is a limit to what private can do. So government says, no, we don't pay immunotherapy. ESI says, I don't pay you. I can show you tons of patients, Kumar, who ESI says no treatment, they won't agree and they go through such huge recurrence because my clinic is recurrent, advanced tumor. So it is appalling the way these people are treated. But nobody wants to speak out because it is not the nice thing to say. But what I want to say is, nice or no, patient is patient. Each patient who comes, are we treating them like they are more my mother, brother, sister or father? No. We are differentiating based on what they can pay. Schemes and other things. So we have to get rid. And I want to say one good thing about the scheme. Orissa model is phenomenal model. Somehow they have embarked on a phenomenal model where they pay as good as private. And I can say today here with our centers in Orissa, they get the same treatment as what a cash paying patient gets. So there are models we have to follow. Maybe Gujarat and Maharashtra are trying to follow others, but it all boils down to finances. And people want to squeeze the system, not pay, it won't work. You have to pay what is the right amount for the right procedure and get the right outcome and measure that outcome. Are we getting the same outcome? You have to measure. You cannot say finances only, you have to measure. If you do cardiac surgery, if you put stent, how many are really doing? Are you putting the right stent? Are we getting the same outcome? Everywhere, whenever you pay money, you have to measure the outcome. Then only I think the system will bring uniformity. This is how you can correct disparity. In my view, I have done calculations, I worked with health economists. There is enough money to do this. If you properly bring about a cess and create a universal health care, it can solve the problem of today. As great Voltaire or somebody said, common sense is so uncommon. We are not using common sense in this because we want to complicate. Simple solution is available. We can put together a team and see how a fund can be sustained and make it happen. Today we can make it happen. But somehow the willingness is not there for reasons which are unknown to me. Okay?
Okay. No, it's crucial you say this. Mr. Pankaj Sahni, I just want to get your thought on this. We mentioned these challenges which we are mentioning today in terms of the way we are looking in terms of government approach, intervention and all of that. This is happening at a time when hospitals are in an expansion mode. If you look at many of the leading hospitals, they're 20 to 40 to 60% actually adding capacities now across the board. In fact, I think max I saw something like 60% addition in capacities. So when there is a threat of this price curve, then there is the issue of, do you think this is going to be the way forward, or will it be like technology, for example? And the reason I mention about technology is, you take the case of oncology, for example. In oncology, oncologist is more, the hospital is acting more like an airport, where let's say an Indigo is actually parked and the passenger goes for Indigo, not for the airport. So similarly in the hospitals today, the patient goes for the doctor and not to the hospital as such. And then, so can the technology be used so that, the hospital's coverage is taken to remote location, the same oncologist time is leveraged much more, and therefore greater gain? I mean, is there a way in which the hospitals today will look at the way they are expanding? Is the newer realism given the challenges now?
So I think a few clarifications because there are also some assumptions in your statement which are not actually playing out. All hospitals are talking about expansion. I don't see that many buildings which are coming up from the ground. And unfortunately, one of the reasons they are talking about expansion is because there is a looking like a seamless flow of money flowing into the private hospitals. Arguably, at least from my point of view, not all of it rational. And like with many things, there is a unhealthy push to say that today healthcare seems like a very sunrise industry, and suddenly everybody has got overly excited with themselves to say that there is a lot of money to be made in healthcare. And what has changed? Everybody asks me what has changed from 3 years ago, and the real answer is nobody knows what has changed. You guys have got overly excited, and that is resulting in sometimes unhealthy situation in healthcare.
By you guys, you mean what?
By that I mean that there is an unhealthy focus on, as Dr. Ajaikumar was saying, margin growths, unhealthy focus on finances, unhealthy focus on things like how many more beds are you adding, what will be the kind of financial return on these things. Nobody's talking about the things that matter, which is what is the quality of care that you're delivering, how are you actually thinking about addressing all of these things with respect to serving the community. So a lot of the conversation is around M&A in the industry. M&A doesn't add additional beds to the country. It only adds money from one person's pocket to another person's pocket.
That is true.
So I think that the narrative is wrong and the narrative needs to change, and I think some of the things that you're seeing as a reaction is because of this narrative is wrong. So that's one point. But to your question around all this bed capacity being added, people are talking about it, but you see a hospital doesn't get built overnight. It takes 3 to 4 years, even if you start today.
That's true.
So this is a very long journey. And by the way, it's very easy to build a hospital. It only takes money. Where are the doctors and nurses to run this hospital?
Yes.
Even whether it is in the government or the private, half the hospitals that are existing today are non-functioning. Maybe we should first focus on renovating those hospitals before we talk about building new hospitals. These are the challenges which is there, and I think that a lot of this is because we are having the wrong conversation. Now, to your question on technology, I think that there also we are having a conversation at a very superficial level. Will technology be important in healthcare? Of course, it goes without say. But Dr. Ajaikumar treats patient if he is using technology to treat a patient, and the advice to the patient is that you need to come and get radiation oncology treatment at a LINAC hospital, at a LINAC which is probably existing in a hospital. Technology is not doing anything because that consultation doesn't have meaning, because if the patient cannot reach that machine, what will happen?
Right.
So I think we have to understand technology is a tool. And that tool is there to assist a clinician to deliver care to a patient. Technology doesn't take away the clinician. Technology doesn't take away the need for healthcare institutions. Technology is a means to deliver care. And as long as we understand this, and as long as we understand that fundamentally what you're doing is you're providing an asset in the hands of a caregiver, normally a doctor, to try to see can they deliver care in a better, faster, more efficient and cheaper manner, then you are fine. Unfortunately, we think that telemedicine will solve India's healthcare problems. It will not. It's required, but it's just one tool.
Very true.
At the core, what you're looking for is these things need to stitch together. So we need to stop thinking about single solutions and start thinking about ecosystem solutions. And that requires, again, like I said, a multitude of things to happen. Today, half the things that a nurse is allowed to do in the US, a nurse is not allowed to do in India, not because they are not trained, but because there's a rule or a regulation which doesn't allow them to do these things. Right. We need to break down these barriers and address them at an ecosystem level if we are to solve our challenges.
No, I think, in fact, good that you gave this example of nurse which you mentioned there, because if you say in US, for example, unlike in India, you step into the hospital and you directly talk to a specialist. It doesn't actually. You don't need to, and in fact, hospitals don't need to have so many people there as well. So when I was mentioning about technology, I was also mentioning from the perspective of having protocols in place, having people who are not necessarily the doctors there who are actually screen and tell in terms so that we can use the resources that we have in a much more efficient manner. Will that be a challenge to be able to do that? Is setting the protocols, getting to that levels where we actually can do that? Is that a challenge? I mean, why aren't we able to replicate that? Is it to do with the regulation?
No, I think that again, there's a nuance. So, changing protocols, setting up things, can it be done? Of course it can be done. Is it a challenge? Yes, it's a challenge because it requires change management, and all change is hard. Maybe more so in healthcare than in other fields. It can be done. I think, can regulation in some cases be eased to make life easy? Yes, it can. So today there are many regulations that prevent healthcare from being delivered in a more meaningful manner. But we also have to understand that some of these regulations are again reactionary to some of the things that were mentioned around the errors that happen. So we have to look at it from point of view of saying, are we skilling the staff? Are we still skilling our people to be able to deliver this healthcare? Today, at least when we hire in our system nurses, I would say 70-80% of the nurses who claim to have worked in an ICU have never seen a ventilator.
My goodness. Oh.
So it requires us to train them for at least 45 to 60 days before we allow them to work in an ICU. Yeah. So there are very big challenges in how we think about standardizing protocols, because you can put lots of things down on paper and you can talk in offices and conference rooms and on PowerPoint. Finally, what you're talking about is dealing with the interaction of a doctor and nurse dealing with human lives. And that, I think, requires a lot of very micro addressing, micro hand-holding for how we actually make these changes. Yeah. And unfortunately, that takes a lot of time.
Yeah, thanks. Dr. Verma, as we conclude, I see that the time's up and I want to minimize extending the day. You mentioned always, in our interactions, you've always talked about research. So when we talk of healthcare now, how do we ensure that there is greater research and greater rigor in the way we look at it, greater collaboration in the way we look at the way emerging sciences, neurodegeneration or whatever. And so some thoughts on that, and a final point which I want from all the speakers. Sorry? Yeah. Yeah, not for us. Yeah. And the final point which I want from the speakers is essentially just a thought, as a concluding thought for takeaways for the people would be essentially post-elections, perhaps if you were to look at the 6 months to 2 years time period from now on, what would be 2 or 3 points for the healthcare sector that you would think needs to be done immediately, which can be done by the state and by the private, which we can talk as some fixed points where we can move. I'm not talking of long term as in 10 years or 20 years later. As John Maynard Keynes, the economist, said, in the long run, we are all dead. We're not looking at that. Just about 6 months to 2 years. That will be my last point with which I end. But before that, a quick thought from you on the research thing, which we seem to be losing edge on.
Yeah, of course. Thank you. Research is the backbone, it's the core, it's the mother of the progress, which leads to the innovation, and the innovation then can be put to the kind of equipment, the technology that we are using for the patient care. So from that perspective, and we have a huge focus on research at AIIMS. We have a separate research division, and currently we are running about 1,000 research projects, which are funded by the different funding agencies and our own institution, and the funding is to the tune of about 200 crores. So I think it's important that, yes.
But time-bound fashion, outcome-driven, so that there is something which we can say that, this has led to this. This is where the private can step in. That kind of a thing.
Absolutely. We are creating that environment also. We are creating, say, the entrepreneurship center there in our institution, where the startups are being encouraged to, they have the ideas, they can just come there, test their ideas, and then lead to the innovations, which is what we have set up 2 centers now, one in the main campus and one in the other campus, which is at Haryana, Jhajjar. And the emphasis is that research may not just be the publication, the doing something, putting up in the in the journals are publishing this, it should lead to the innovation which is patented, and then the technology is brought to the people and to the clinician and the doctors for the larger public good. And I think it's not just us who can be. The private sector can also participate in various ways in the research process. If not something else, at least the data that they have, the data can be of enormous use. And now we are setting up a data science center also in our institution, just to look at this, to use this data for the enhancement of, say, improving the quality of care that we are giving to our patients, to our people, and also trying to use this data for the future foundation of the research. Okay. So I think it would remain critically important that we should keep engaged into research also, which we are doing. And I would, in fact, suggest that, yes, even we are willing to join. In fact, we are running clinical trials from the pharmaceutical companies, from the private agencies that we are also strictly regulating and doing the trials, which are being done the private sector, the private hospitals also. But I think they can also join us in that venture. And we are inviting, in fact, the people from the industry that, yes, they could come and collaborate with us to bring out new innovations for the public use.
Okay, yeah, great. So we'll conclude with that. Dr. Ajaikumar, you also look in terms of research. You've been doing a lot on genetics. You've been doing a lot of AI, and all of that has been also happening in your end. Just as concluding thoughts, if just as takeaway for the people listening to you, 6 months to 2 years time frame, what would be the 2-3 specific areas where you think for the healthcare, the access, affordability, competitiveness, universal, whatever you're saying, some things which can be achievable, which would be the first 2 tick boxes from what state can do and what private can do?
I think state being, you say state is, health is a state issue. And we talked about GDP, but one of the things we didn't talk, which I think is enormously, apart from research, I think research is an integral part of any institution now. We cannot claim we are academic research or caregiver. All of them has to be done. Data has become very important. From the government viewpoint, I think what we miss here is, with enormous knowledge we have, knowing like inflammation is the common cause of cancer, others, there should be a lot of emphasis on prevention. I think once you, like for example, if you curtail smoking, or I know we are in a ITC hotel here, but if we can just ban tobacco, 40% of your healthcare issues are solved. Just solved. We don't have to see advanced cases, lung cancer, tongue cancer, or even cardiac issues. But I know it is a revenue, that's what the government says, revenue earner and all. But we are again caught in this catch-22. So I think government, maybe post-election, should look at how to curtail smoking, how to encourage alternate farming, which we are doing as private enterprise. We like to go out of business. So there is no doubt, but this is a doable. It is easily doable while we talk about cost of healthcare. This is one which will dramatically bring down the cost. So in my view, I call it medicine C. There is medicine A, when we are sitting here, I have a heart attack, I'm taken to the hospital. Medicine B is I have some headache. I say, oh, you have blood pressure, that is medicine B, let me treat you. Medicine C is the most important. We can actually prevent a lot of diseases. And in a country where we are so much bothered about the cost, this is the best way to take care of major diseases. And there is so much research going on. Do we all know that cancer, diabetes, Alzheimer's, cardiovascular disease are all interrelated to inflammation? Smoking is a form of inflammation. Okay. So human papilloma virus is inflammation. We can eradicate. So we should focus on that. And second point is universal healthcare, which I again repeat. Yeah. These are my 2 things which can be
very important. Atulji.
Yeah, thank you so much. One clarification, NABH is a voluntary body. Worldwide, quality is a voluntary initiative. It's one step slightly above the regulation. But government incentivizes us so people perceive it as regulator. There's a big tangible to be made. There's a 15% upmarking against the IRDA published rates if any hospital subscribes to quality standards. So we are constantly working on already the wish list. One, we are trying to demystify digital health. We have already released the digital health standards. Already 145 hospitals are there in 2 months. assessments. The basic idea is how to leverage, as Mr. Pankaj has said, what to make sense of technology. So silver, gold, platinum, we are there. That's already there. We are working, for example, with Tata Memorial Hospital on the National Cancer Grid to onboard. You've already onboarded 263 hospitals working for a clinical decision support system for oncology. This is with Koita Foundation and TMH. We have a MOU. We're working there. So that's just one example. We are also, I totally agree that in case we are to make a tangible difference, then we are to strengthen the weakest link, have a top-up approach. We have to, we cannot get away by building islands of excellence. We have to strengthen the primary care, the tier 5, tier 6 level things, and that can only be done if all of us know that working towards universal health, that's one, but we have to mentor the handhold everyone. So government has its, no doubt, but I'm extremely optimistic about already the processes which have been set in motion. For example, there are 150,000 health and wellness centers. As a first part, we have taken it upon ourselves to assess capacity build, gap analysis, and bring them to a certain level, 12,500 of them. So already 1250 have been done, but it's a long journey, no doubt about it, but already there. Okay, right? So that's one step. But also somehow, I mean, bottom line is that we have to, it's all in the scriptures also. There's a very famous shloka, Sarve Santu Sukhani Sarve Santu Niramaya. That basically means we can all be only happy and healthy if everyone around us is happy and healthy. So that's the bottom line to take away.
Very nice. Pankaj, optimism or hope?
No, I think that I'm definitely optimistic. I think, frankly speaking, if you look at where we have come, it's a long way. So it's very easy for us to get into a pessimistic orientation around everything that is wrong. But we have to actually look at how far we have come. And I think everybody has mentioned our outcomes are as good, if not better, than any other country in the world. We deliver healthcare of this quality at a cost which is, 1/10, 1/20th of what you see in the West.
So your wish list in the medium term?
I think the wish list is very long. I think that my basic thought is that I think that we are still all groping in the dark. We are not talking to each other. We don't have any clarity. So my wish list would be, if there is a very clear and concise vision of exactly what we are trying to achieve as a country in Indian healthcare in the next 6 months to 2 years, as you say. Because if I go and I actually survey all the leaders in the private or the government space, I don't think anybody actually knows what are we really trying to do. And I don't think there is actually a very clear idea with what the government wants us to do. So my first point would be, can we actually transparently lay out what is our joint vision at a very practical level? And I think for me, many things will then come from there.
It's a very important point. You get the last word, Dr. Verma. AIIMS gets the last word.
On what?
On this whole deliberation that we've had with a distinguished panel that has traveled all the way. Dr. Ajaikumar has come all the way from Bangalore to Mumbai to Delhi to share his insights, and all of you have spared your invaluable time. So some thoughts in terms of, what do you think? I mean...
I think there has been a phenomenal change in the healthcare delivery over the years, and we are doing exceptionally well in many areas, including providing the healthcare to the poorest of the people at the lowest of the cost and the best that anybody in the world can provide. We have people flowing outside from other countries for seeking healthcare, getting the treatment, and early care. And we have improved over the period of time, and we are consistently improving, both in the private sector and in the government sector also. The most important aspect from our point of view remains that we need to strengthen the primary health care, which we have been talking repeatedly. And for
one thing which can be done for primary, we'll end with that. One thing which can be done for primary, because that's the first touch point, and we'll end with that. One thing that you think can be done.
Yeah, one is that staffing is there. The facilities and the infrastructure creation is a problem. That government has to understand and support this, that is the infrastructure creation, the facilities which needs to be provided. The staff is there. But when the people go there, the services are not there. So they are forced to come to the cities, to bigger cities, to bigger hospitals. So that primary and secondary healthcare needs to be strengthened. The tertiary level we are doing, pretty well. But tertiary level cannot look after the primary level problems. And eventually what is happening, the AIIMS for the Delhi is a primary health center. And for South Delhi is just the first contact with the doctors. And for some reason they get the access also.
Okay, right.
So I think we are doing well. We would continue to do well, but there are certain areas which needs to be strengthened. And the private sector, of course, has got a very important role in this.
Yeah. Atul, you were saying something? I missed. You were saying something, I thought.
No, not to steal the thunder in the last word, but only point is that government has set about, bringing its own house in order. So there's a renewed focus from the top on healthcare quality. Of the 22 new AIIMS, sir, 18 are now applicant with NABH, 4 have already achieved it.
Okay.
Similarly, in the last 2 years, 150 bigger hospitals across India, they have got the NABH accreditation. So with or without the certificate, the focus on quality from the top in public funded institutes is, I think, is a huge accountability which is there. Secondly, integrated, everyone mentioned that we need to use the resources. So there are 267 homeopathic medical colleges, there are 554 Ayurvedic medical colleges, and what to speak about yoga, naturopathy, Unani and Siddha. So all these resources, I totally agree with the nurse practitioner model which is so successful in the US, but in India we have trained doctors by and large differing in the therapeutics. And they come through a structured program, they come through NEET nowadays, right? So that integrated model, which is very essential, can be one of the solutions. But
Great.
we all, I agree, totally need to come back on the table, discuss it frankly, thrash out the issues, and then churn out a solution and set timelines for probably 6 months and 2 years.
Great. Thanks so much. Emphasis on integrated and on quality. On quality from a high quality panelist like this is incredibly nice. So thank you so very much.